Hi, everyone. So this lecture is going to be about the rest of the lower respiratory diseases that we did not cover in class. So in class, we covered pneumonia, bronchitis, pleural effusion, atelectasis, and pleurisy. And so for this lecture, you're going to find tuberculosis and the environmental disease. So let's talk about tuberculosis. So tuberculosis is pretty much a infection that also affects that alveoli or that parenchyma that I kind of talk about it in class, and it's due to this Bacillus gram-positive bacteria called Mycobacterium tuberculosis. And so, this bacteria is sort of interesting because not only can affect your lungs, but it could also affect other parts of the body, like other organs, like, for example, your brain. Okay. Um, it is considered pretty, I'm not going to say like infectious because you have to sort of be next to it for prolonged exposures and then close contact. But it is a health concern. It's reportable to the Department of Health. And there's quite a bit of things that, if not taken care of, can lead to declining on that person. But pretty much it's considered an airborne droplet precaution. So, meaning it could be spread through droplets. Um, and it is also another thing about it that is interesting is that is pretty sensitive to the ultraviolet light and the heat. And so that's going to come in handy when I kind of tell you what we do for these clients, what we kind of where we place them in the hospital. Um, let's see, who is at risk for tuberculosis? Well, mainly the people that are homeless or have a very immunocompromised immune system, uh, people from other countries that may be underdeveloped, or maybe around poverty or drug IV users. Of course, us healthcare workers, because we might be in contact with these individuals. And so those are mainly who are more at risk. And needless to say, of course, if you are exposed to someone with close, frequent, and prolonged exposure. So just let me kind of go over a little bit of the pathos so you understand. Again, keep in mind that when we talk about patho, it's not something you have to sort of memorize. We're not going to ask you the patho in the exam, but we do need you to understand a little bit of how it comes so you can apply some of these concepts. So we have these particles that kind of float around after someone has coughed up or sneezed or is talking, and they sort of leave this nuclei um, of the evaporation of the particle. And so that's kind of what we either get in contact with, or and we also breathe in. And those lodge in your alveoli or your bronchioles. And so that is what the immune system recognizes as, whoa, this does not belong here. This is something that we sort of need to kill. And an inflammation process starts occurring, and then your T cells, your fighter cells, lymphocytes will kind of enclose the bacteria to try to control it and kill it. But then in your immunocompromised or people that may not have a strong immune system, the wall that these T cells sort of create around the bacteria, it breaks, and that's how it starts spreading to other parts. What you see on X-rays, it's literally these calcified, they're called gone lesions, and that's what you see from the calcification of the bacteria being enclosed by the T cells. All right, so let's see. There's different classifications, 0 meaning no TB to 5 being it's suspected. This is in page 605 of your book, so you can kind of refer to that and just kind of see what the classification is. You could have latent TB infection, but not the disease, meaning it's sort of like just dormant, kind of there, like you've been exposed. But so here, moving on the next table, I will show you, and feel free to pause me, pause the video. Here is a comparison table of what it means to have latent tuberculosis and active, full-blown tuberculosis disease. So if you notice on latent, you might not have any symptoms, it's kind of dormant, it's kind of sleeping, but for your active tuberculosis, you do, okay? Um, on your latent, maybe you are not feeling sick, okay? You cannot spread tuberculosis to other people versus on active. Yeah, you feel sick, and yes, you can spread it because it's active. On your latent, you could have a skin test or a blood test that is positive, but maybe a sputum culture for TB that is negative, okay? Or maybe you might not see it in in a chest X-ray. In country, with active, yes, your blood test is going to be positive, your sputum is going to be positive, and your chest X-ray will be abnormal. For latent, we do need some treatment for latent tuberculosis to kind of prevent from becoming active again. And then when active is when you have active tuberculosis, then yes, you do get this full-blown multiple tuberculosis medication and some antibiotics and whatnot, which I'll talk to you here shortly about. So, what are the symptoms of tuberculosis? Well, symptoms really do not appear until possibly 2 to 3 weeks after the infection or reinfection or reactivation if you have latent tuberculosis. But for your symptoms, you're going to have this sort of dry cough that could be productive, and it's going to be for lots of weeks. Okay, it's just kind of hacking, it's dry. You could have these normal or abnormal lung sounds. But some of the things, because again, the dry cough and for weeks can sound like bronchitis, right? But here are the things that are key to tuberculosis. You get really fatigue, anorexia, weight loss, and these night sweats that are very, very sort of hallmark to tuberculosis. And then you have possibly this coughing of blood or like like a tinge of blood in your sputum or mucus in the late stages of tuberculosis because of the inflammation that happens and whatnot. Okay, so that's how you can kind of differentiate from other diseases like bronchitis or pneumonia. We diagnose it based on a skin test. That's sort of the standard method. It's the tuberculin skin test, and I'm sure many of y'all have gotten one of these. It's intradermal. They inject just a little part, a very small amount of the protein in that forearm, and then you read the results within 48 to 72 hours. If you're looking basically for any redness, any induration, the induration is usually measured by millimeters. And so I kind of gave you a sort of a guide here. And then, that's to kind of say that it's positive depending on how big or whatnot. Now, the results do need to be read no sooner than 48 hours and no later than 72 hours. Another way of testing for TB is that you can get a T-spot, and it's really a blood test now, and they're looking for kind of like your antibodies of the blood. And so if that's positive, then you can either have it or have had it in a way, and then you basically do other tests like chest X-ray or whatnot. The sputum studies are your gold standard, but again, you have to provide a sputum culture. It has to be 3 consecutive sputums. It got to be collected in different hours, and it can take up to 3 weeks. So, although it's the gold standard, it's not the standard method because it does take multiple sputum consecutive specimens in different hours, and um, the test takes many, many weeks. And in that time, the client could be infecting others. On the X-ray, they're looking for those gone lesions that I was mentioning, the encapsulated granulomas. So if, let's say, your skin test comes back positive, you've had TB in the past, or you've had the vaccine, um, mm, then not the vaccine, I'm sorry, my apologies. You've had the actual TB, or in some countries they do give you, well, it's kind of sort of like a vaccine. It's an injection. Then you could become positive, and so they'll do the chest X-ray to look for the lesions, basically. So then, if you have TB, the treatment is outpatient, and it's not only outpatient, but in most of the cases, but it's also very tightly controlled by the health department. And the reason for that is, think about the individuals that most likely will get it. Your homeless people, your IV drug users, your immunocompromised, maybe foreigners. So the non-compliance of the TB drugs is very high, whether that is because they cannot afford it, which is really, really expensive, or they just simply don't pay attention and don't care. So, for the most part, the treatment of these drugs is considered monitored by the health department through a direct observation therapy, or directly observed therapy. We abbreviate it as DOT, to make sure that the client sort of complies with the treatment. Um, the patient is usually considered infectious during the first 2 weeks, and we have to educate them over and over on sort of what to do. So they basically are told not to be visiting people and being exposed where they can spread the disease. They should avoid public transportation, try to stay in their home, kind of like isolated, sort of like what we've been doing with COVID. Lots of hand hygiene and oral care. And then, they are given multiple of these drugs that I have here listed. And they have, kind of weird names, but I try to sort of highlight with different colors what's special about them. So, for example, everyone that starts with an R, like the rifampin, the rifabutin, and the rifapentanine, they all start with R, and they all basically change the color of your sputum, your urine, your tears, your sweat, any bodily fluid. Okay. If you notice, they all sort of cause hepatitis. So they are very harsh in the liver. They're filtered by the liver. So we have to be careful. The one with the P, the pyrazinamide, causes joint pain. And I kind of highlighted pain because it starts with a P. Okay, P and the pyrazinamide, you can relate that. And then the other one that starts with an E, um, it causes ocular toxicity, or it can cause ocular toxicity. So eye ocular, um, where it changes your color discrimination, your green and red discrimination. So just, I try to kind of see how you guys can remember some of these meds when you see them and recognize what we teach our clients about. So some of these side effects or adverse effects, you do want to teach them because they want to know, like you would want to say to the client, hey, listen, if you take rifampin, you could have your urine, your sweat, your tears change a different color. So that way they don't get scared. Keep in mind, and I said this earlier, that these drugs are really, really expensive and they might be on one or two or possibly three, okay? They are also prescribed antibiotics, and I sort of listed them here in your canvas as well. I do have a table with the drugs as well, okay? Just for your reference. So what do we do as nurses? Well, we need to assess, and recognize this early. And we presume that everybody with sort of similar symptoms, or maybe they've traveled to a different country, or they're foreigners, they are presumptively positive until ruled negative. Okay. That's the same thing we've been doing also with COVID. So we assess for the signs and symptoms. We isolate them immediately, okay? Whether you're positive for sure or you are presumptively positive. And we put them in airborne precautions, which means they're going to be in a gown with an N95 respirator mask. You're put immediately on, a private room that is a negative pressure room. And what negative pressure room is, that it filters the air. It doesn't let the air kind of come out of the room. It basically, the air is expelled out through these vents. And so basically the air is sucked into the room and out through the vent. Why? Because the bacteria doesn't like ultraviolet or heat. So that is why it's in a negative pressure room. When you see negative pressure rooms in the hospital, if you get the privilege of seeing them, they have this anti-room that you sort of get dressed and put on all your gear before you walk into the door of the negative pressure room. So it's kind of very important to put signs, and everybody needs to stop at the nurse's station, make sure that you have kind of like your appropriate PPE and that you are allowed in the room. And we sort of eliminate or avoid as much possible any exposure of these patients in the hall. So, if they need to go to, let's say, radiology or whatnot, we want to minimize the exposure time, and we want to have them with PPE, full PPE, before they leave. All right, so what else do we do as nurses? Well, if they're having dyspnea or difficulty breathing, or their saturation is low, we want to give them oxygen. We want to help with their lung expansion and their breathing. So you can do that by elevating the head of the bed. They get very fatigued, right? And tired. So we want to hydrate them. We want to help them with their ADLs. We want to provide some bed rest and also energy conservation. Like maybe you can cluster their care. Um, that way, you're not doing something, and exhausting them every so often. You might have to do small bites and frequent meals with high calories, high carbohydrates, vitamins, proteins. We do give them bronchodilators and steroids because of the inflammation that happens to open up the pipes, the airways, so they can breathe better. Um, I should have put this contact public health department first because it is reportable. And so one of the first things that happens is that we report it to the health department saying, hey, we've had a active TB case in hospital such and such in county such and such. Meticulous hand washing, comply with the PPE at all times, and then they usually are advised to cover their nose and, maybe dispose their paper into paper bags or down the toilet so the bacteria is killed. Let's see, I was going to say something and now I forgot whatchamacallit. Oh, yes, it's sort of similar. I don't know if you agree with me, but it's sort of similar to kind of a little bit of what we've been doing with COVID. I mean, it's not the same, granted. Let me make that clear. It's not the same, but it's sort of similar, resembles, and sounds like a little bit of what we've been doing with COVID. So here's a little easy to read. If you are more of a visual person, please feel free to pause it and take a picture of it. And then we're going to talk about the environmental lung disease. So, environmental lung disease is literally this disease that results from inhaling dust and chemicals and these very fine little particles. They're usually related to the environment or a a type of job that you might have, okay? So I think about environmental lung diseases when I see people in mines or when I see individuals working at factories that maybe have a lot of chemical fumes, or maybe they work with fracking, taking out the dirt that they filter sand because that sand is used for fracking for the oil. So the very small particles, and they're basically inhaling these particles in a daily basis. So it damages the lung. Now, in order to have this lung damage, you have to consider what kind of chemical or substance it is, the amount, the duration, and how susceptible you are, right? If you have other comorbidities or other respiratory issues on board. This is something that happens over a long period of time. We're talking about years, 10 to 15 years, that you might not see symptoms or signs, and you're just damaging your lungs, basically. It's one of the causes for COPD, the chronic obstructive pulmonary disease. So we're going to talk in a different lecture, and also lung cancer. So it manifests with literally shortness of breath, cough, and wheezing because of the inflammation and the damages to the structures. You lose a lot of the vital capacity of the lungs, so they cannot exhale as they normally do. So they hold on to CO2. And then they're kind of always tired, they lose weight and they get really tired. Really, to treat it is prevention, and that is why we have departments such as OSHA and NEOSH that protect us. So, for example, OSHA is this regulatory committee that enforces safety to make sure that your employer is providing the necessary things for you to not basically develop an environmental lung disease. So if you work on this mines or whatnot, that you have your proper respirators and your mask and shields and goggles and whatnot. You can use oxygen, you can use bronchodilators, steroids. Again, they open up the pipes and they decrease inflammation. Clients are encouraged to stop smoking and also receive all their vaccines. They could use pulmonary rehabilitation, so sort of like a rehab, but for the lungs. They do a lot of breathing exercises and just sort of helps the lung in a way catch up and kind of work its way to maybe the best potential that it could be. It doesn't fix it, but it's just sort of like working out your lungs. Think about it about the gym, like it's like a gym for the lungs. But yeah, early diagnosis and prevention here is going to be key. Okay, well, as always, my references are from the book, and then all images are obtained from Google or the book. And I'll see you in the next lecture. Bye bye.